Thank you very much, David, and thank you to the organizing committee for having me here today. It's a real pleasure to be in person at a meeting. And Christoph, I don't know what you mean about the weather. For us from the Norwegian countries, it's lovely. So let's discuss today about reducing stroke by screening for atrial fibrillation. As just pointed out to us, patients with atrial fibrillation are at an increased risk of stroke, mortality, and in fact, this risk can be reduced by the use of oral anticoagulants, albeit at a small cost of bleeding. What has not been known is if we should try to detect these patients early, initiate oral anticoagulant therapy in order to prevent strokes. Indeed, should we screen for atrial fibrillation to avoid strokes? Well, let's have a look at our guidelines. Well, indeed, according to the ESC guidelines, we should do opportunistic screening for atrial fibrillation. So everyone who's above the age of 65 coming to their doctor for any reason should be screened for atrial fibrillation using pulse palpation or a rhythm strip. However, if you're older or have risk factors, you might be screened systematically, that is, by inviting a whole segment of the population. But if we look at the United States Preventive Service Task Force, they have quite a different recommendation, concluding that the evidence for screening is in fact insufficient. So how come these two major organizations have such different recommendations? Well, we do know that if we screen for atrial fibrillation, we will detect a lot of new atrial fibrillation and we will be able to initiate oral anticoagulant therapy. The Stroke Stop study was a population-based study. In this population-based screening study, we identified all 75 and 76-year-olds residing in 2 regions of Sweden. The only inclusion criteria was age. There were no exclusion criteria, meaning that even if you had severe dementia residing in a nursing home, you would still be included in the study. And this was in order to mimic how a population screening program would likely be set up in Sweden. Overall, we identified approximately 28,000 individuals. They were randomized in a one-to-one fashion into a group to be invited to screening or into a controlled group. After our screening intervention, we followed all the participants or all the randomized individuals for approximately 7 years with regards to our primary combined endpoint. So this was a combined endpoint of stroke, all-cause mortality, and also severe bleeding. The groups were well balanced, on average 76 years of age. A majority were women, as expected in this age group, and the most common comorbidity was hypertension. Of course, just because you're randomized to be invited to a screening program doesn't mean that you will participate. We invited all those in the group invited to screening per mail to attend our screening centers, and approximately half chose to participate, so more than 7,000 individuals. We could also see that those choosing to participate in our screening study were overall more healthy compared to the non-participants. Not shown on this slide is also the fact that they had a better socioeconomic standing overall. Those choosing to participate, if they did not have known atrial fibrillation, they were asked to do intermittent ECG recordings twice daily for 2 weeks. In the case that we detected new atrial fibrillation, we organized a systematic follow-up by a cardiologist. Also, for patients with known atrial fibrillation without oral anticoagulation, we organized a systematic follow-up in order to initiate oral anticoagulants. Through our intervention, we could see that we could increase the diagnosis of atrial fibrillation in the group invited to screening as compared to the control group. What about the primary endpoint then? Our primary combined endpoint of stroke, all-cause mortality, and severe bleeding. Well, in the group randomized to be invited to screening, we could see a small yet statistically significant reduction in events with a hazard ratio of 0.96. We needed to invite 91 individuals to prevent 1 event. But today's topic was actually to see if we could screen and avoid stroke. And on this outcome, which was a pre-specified secondary outpoint for ischemic stroke, there was no statistically significant difference between the groups, nor was it on an unpublished analysis any difference with all-cause stroke. However, if we look at the group that chose to participate in our screening study, we could see that there was a great reduction in ischemic stroke. The hazard ratio of 0.76. We tried to adjust because we did know that these groups differed significantly, the participants and the non-participants, and we tried to adjust for all things we could consider in our registries. This remains significant, but of course, this is only an exploratory analysis. This is not the intention to treat analysis, so must be interpreted with caution. Just a reminder, as we were talking about stroke, of course, Jesper just presented the fact that they also had similar outcomes with no effect on stroke, but also in their protocol analysis, there was a significant effect. So a very minor change in the group that was randomized to screening in the stroke stop arm. Could this very small difference between the group make any difference? Well, if you look at the cost effectiveness study, and this was just shown during the ESC Congress, you could see that using a lifetime perspective and inviting 1,000 individuals to screening, actually you can gain 65 quality adjusted life years and at a lower cost. And this analysis was performed by Professor Lars-Åke Levin at Linköping University. I will not go through this busy slide. These are the two studies that we have discussed today, none of which has actually been able to prove a difference with regards to ischemic stroke. So what should we do now? Well, hopefully the answer is already here in the future. The SAFER study will randomize more individuals, and hopefully we shall see a difference also in the outcome of stroke. So, ladies and gentlemen, to summarize, population-based screening for atrial fibrillation provided a net clinical benefit in our elderly population. I think efforts need to be made to increase participation in atrial fibrillation screening. We could see that the non-participants in our study were at a high risk of adverse events. Population-based screening for atrial fibrillation is cost-effective and a good use of healthcare resources. So, thank you very much.